Welcome to the Terminology Leading Practices stream of the SNOMED CT Expo 2021. My name is Liara Tatina and I am Customer Relations Executive for Asia and Pacific and Education Lead at SNOMED International, and I will be moderating today's session. Please use the live QA in your AirTouch device to type your questions to presenter. All questions will be answered at the conclusion of the presentation. I'm now pleased to introduce Genevieve Westacott from Jameson Trauma Institute, who will be presenting developing approaches for using SNOMED CT for surveillance, reporting, and research within the Queensland Trauma System. Genevieve, please proceed.
Hello everyone, and thank you for allowing me to participate in this year's SNOMED International Conference. My name is Genevieve Westacott and I'm a Health Information Manager at the Jameson Trauma Institute. The topic I'll be speaking about today is about developing approaches for using SNOMED CT for surveillance, reporting, and research within the Queensland Trauma System. I will give a brief overview of the Queensland Health Services and digital systems, how SNOMED CT is used in Queensland and the problems it has caused, and finally, the solutions currently in development. Firstly, I would like to acknowledge the traditional custodians of the land I'm presenting from and pay my respects to their elders, past, present, and emerging. I would also like to extend this to any Indigenous persons presenting or listening today. For those of you who have not heard of us, the Jameson Trauma Institute is a team of researchers and clinicians based out of the Royal Brisbane and Women's Hospital in Queensland's capital, Brisbane. We have a passion for data and are dedicated to delivering the best possible patient care through improvements in injury prevention, research, health services and systems, and clinical management. We have a strong collaboration and partnerships with other agencies as we like to take a multidisciplinary approach with healthcare. One of our closest partnerships is with the Queensland Injury Surveillance Unit. They were established in 1988 and have been collating injury data since 1999 from a number of emergency departments and participating hospitals across Queensland. Their collection of injury-related information from Queensland hospitals is invaluable to our research, and we are grateful to be able to work alongside them. So, why is injury so important? According to the World Health Organization, traumatic injury has become one of the main causes of death and disability worldwide. It burdens not only the patient, but also their families, community, and the healthcare system. Often there are ongoing costs and treatments and surgeries, rehabilitation, associated out-of-pocket costs, and the general disruption to life with the potential of never returning to normalcy if the injury is severe enough. It drains the economy, the healthcare system, and leaves patients needing much support and help from their families and communities. As such, there has been much work internationally to reduce this avoidable stress. Injury is a very comprehensive term as it encompasses many conditions, from accidents, poisonings, and falls to motor vehicle crashes, traumatic brain injuries, and even simple injuries such as fractures and dislocations. There are many different components to consider. When analysing injury data and information, often the mechanism that causes the injury is just as important to investigate as the injury itself. It can suggest that if the injury was accidental or deliberate, if there is any issues with a product, for example, a child's toy, or even the place where the injury occurred. Analysing injury mechanism and cause is at the heart of injury prevention. In Australia, each state and territory have are very different demographics and infrastructure. As a result, healthcare services are managed at a state level to ensure specific population needs are met. Queensland is a unique state in terms of population, geography, and systems. While the majority of the population are focused around the southeast corner, the majority of the state is considered rural and remote areas, resulting in decentralisation across the state. The distribution of the public has meant that much of the resources have become siloed and isolated as they have been concentrated around the areas of high population density. This can cause problems for communities living in rural and remote areas as they must travel long distances for extended periods of time to access essential services. To compensate for this issue, Queensland have been in the forefront of telehealth and pre-hospital medicine innovation. Queensland provides many different healthcare services to help manage and care for all types of injuries. To achieve optimal recovery, it has been recognised that a combination of services is required to work together to support patients in all aspects. Queensland healthcare services are unfortunately very disjointed and often feel disconnected and fragmented. Much of this is the result of decentralisation of resources across the health service and changes to funding. A reliance on pre-hospital and retrieval services has formed to ensure equitable access to healthcare services as they are able to transport patients to appropriate hospitals and healthcare facilities regardless of location and local resources. The digital systems and software within Queensland Healthcare reflect this fragmentation as each service have their own specially designed system. Each system can be seen as an information repository with its own language, classification, and encoding tools. There is very limited integration between systems and platforms. Often updates and modifications occur in isolation. This is being recognised as a significant issue as information is unnecessarily duplicated and there is no single source of truth, wasting valuable time and money. This is now slowly improving as new systems are developed and implemented with the idea of future capabilities and adaptations. The Integrated Electronic Medical Record, or IEMR, is at the core of these new systems as it supports external software and improves interoperability. It streamlines information collection, storage, and access as it unites systems and processes. Since 2017, the IEMR has been rolled out to multiple public hospitals across the state, starting at the Princess Alexandra Hospital in Brisbane South. SNOMED has been incorporated as part of the IEMR to facilitate communication and information reporting. SNOMED CT has started to be slowly introduced across 14 major public hospitals in Queensland. The rollout has caused major disruptions to workflow due to changes in software and hardware to accommodate the newly implemented systems. It started in the emergency departments upgrading the long-term legacy system, EDIS. The Emergency Department Information System, or EDIS, is the traditional ICD-based database used to capture information and triage patients. It is a standalone application which relies on nurse-assigned codes manually inputted into data fields and typing descriptions into a free text box. As it has been in place for a long time, it has been structured for simple and concise information input and data extraction. EDIS is being slowly phased out in digital hospitals as it has been identified as clunky and isolated from other systems. FirstNet is the new system implemented in Queensland digital hospitals as part of the IEMR. It has been designed to replace EDIS as it has been streamlined and integrates fully into the IEMR. It also supports the assignment of SNOMED concepts when selecting diagnoses. However, as it is new, information isn't presented clearly and data for injury is often missing. This change in diagnostic capture systems has caused major impacts and disruption to statewide systems as it has transformed into a hybrid system with disparate encoded data. The emergency department provides a significant amount of injury and trauma information, making it a valuable and indispensable source of injury surveillance. Reporting and research are two of the most important processes in healthcare. They help maintain medical and public health standards, allow for benchmarking, and encourage further developments and advancements. Any changes to pathways must align with historical methods to ensure continuity of information and future meaningfulness and utility. Most reporting and research pathways in Australia are based on traditionally encoded information, as legacy programs and their procedures have been slow to change. After the IEMR rollouts and the implementation of FirstNet, information that was previously encoded with ICD is now SNOMED concepts. For those of you who don't know, the ICD is the International Classification of Disease, and as the name suggests, is a classification tool used to group diagnoses and procedures, whereas SNOMED is a language tool designed for clinicians by clinicians to facilitate communication. They have very different structures and hierarchies, terminology, and design purposes. Many of the ICD-based systems had no way of classifying or grouping diagnoses, evaluating procedures, and determining costs for this new form of information. This is what happened to the Princess Alexandra Hospital. They were now receiving information encoded as ICD and SNOMED, with no way of comparing or classifying the data. In collaboration with the CSIRO, they attempted to rectify the discrepancies between ICD and SNOMED by developing a mapping solution. SNOMAP is a web-based tool designed to process uploaded SNOMED information and convert it into ICD codes. Using this method, new SNOMED information will still be captured in traditional ICD-based systems. However, this tool was designed for administration processes, and as such, there are several problems within the mapping tool when it is applied elsewhere, like research. As you can see, some of the concepts don't map well into ICD mapping, meaning the important rich information SNOMED provides is lost. An important note that CSIRO described about the amount of ongoing maintenance required for SNOMAP's long-term use. SNOMED CT is frequently updated, meaning that the mapping needs to be updated at the same frequency. This is not an effective or efficient long-term solution. In 2019, JTI began to seed injury data in the format of SNOMED concepts. As the SNOMAP solution is not detailed enough to be viable in injury reporting and research, this meant that another solution needed to be investigated to utilize the rich information SNOMED provides. We also teamed up with CSIRO, and they suggested a matrix category system would be much more efficient and effective for the capture and utilization of SNOMED encoded information and the long-term use of a solution. A matrix based on categories would mean that much less ongoing maintenance and individual concepts and codes do not need updating. Yet, categories can align with old reporting and research methods, ensuring future meaningfulness and utility. Thus began the task of building the categories for the matrix. While the matrix categories have a trauma and injury focus, some of the categories have the potential to be applied in many different aspects of medicine. There are three main category types: body region and body structure, which describe the affected area or body part, and the nature of injury, which describes the type of injury sustained. To maintain clinical meaningfulness, doctors and nurses were consulted on various aspects of the matrix and its categories. It was found that utilizing these types of categories, rich SNOMED information was not lost through a mapping process. Due to the hierarchical web-like structure of SNOMED, concepts assets were able to be used as the basis for classification and categories. As you can see here, the inbuilt assets are able to be used to inform a rule-based system to classify and categorize concepts. The example here is a fracture of hand. It has an associated morphology of fracture and a finding site of bone structure of the hand. Its nature of injury is easy as it is simply a fracture. Its finding site, however, its body region and body structure is a bit more abstract, however. If you go back through the hierarchy of the bone structure of the hand itself, it will reveal it contains a parent concept, hand part, and skeletal structure of the hand. This means that the concept will be categorized as fracture of the skeletal system of the hand. To achieve this on a broader scale, the assets are converted into rules, which in turn create ECL queries to group concepts. Simple but definitive logical parent concepts have been chosen as key rules to include or exclude concepts from categories. This method can cause problems as some body parts are on the cusp of several finding sites, or primitive concepts are not well defined. However, the majority of concepts are able to be easily manipulated into desired categories. Here is an excerpt of our matrix. You can see here that the fracture of hand concept will sit in this highlighted box between fracture and hand. This illustrates the potential of the matrix to be used in a multitude of settings, including clinical dashboards and registries, or even in other medical settings. There are also plans of introducing external cause, intent, complication categories to further enhance analytic abilities. The matrix has been recently granted ethical clearance to test the categories against real-world data, and preliminary results have been promising. So, in summary, traumatic injury causes hefty burdens on patients, their families, and the healthcare system, with ongoing costs and appointments which the government need to monitor to maintain public health standards. Queensland has had a digital movement to improve hospital and healthcare facility processes. This has meant new terminology and language systems have been implemented before appropriate categorization and processing tools have been developed. As SNOMED is a language system, new and out-of-the-box thinking has been required to design and develop methods of utilizing SNOMED data in ways that align with historical methods. Unfortunately, some of these solutions have not been substantial enough to use within the trauma and injury space, meaning more innovation has been developed to form a category matrix system. While the matrix system has not been finished yet, it has been shown to be promising and holds potential to be applied in multiple spaces within the healthcare field. I would like to thank the Queensland eHealth Department at the CSIRO for their ongoing support and collaboration with this project, as it would not have progressed without them. Thank you all for listening.
Thank you, Genevieve, for your presentation. Can I ask that attendees give us a moment while we switch over from our pre-recorded content so that Genevieve can address the questions you have by submitting live. Please note that this session will be available on the event platform for the next 3 months. We would like to invite questions. Please enter them in the chat box and we'll do our best to answer them. In the meantime, Genevieve, I have a question for you. So what's next once the work has been finalized on the matrix solution? How do you see the next development happening in your work that you've been doing so far?
Well, we would like it to inform actual code assignments in the hospital place where the nurses and the doctors are actually assigning them to help facilitate communication and sort of regulate what concepts are actually being used. So it would be nice to see it properly integrated into our IEMR, but also in other medical fields, as we have a number of different registries across, not just across Queensland, but across the entirety of Australia.
That's fantastic. And another question I have is, looking forward, once the solution has been finalized and implemented, like you just said, what do you think would be the biggest benefit area that SNOMED implementation can provide to research community in particular?
Just the richness of information that SNOMED can provide in just a single concept. With other classification tools, you need two or more concepts to get that detail to explain what exactly is wrong with a patient. Whereas with SNOMED, you can just have one code that'll have so much information held within it.
Right. That's great. Thank you. Thanks for that. So we'll give a few more seconds for the audience to type in their questions. And in the meantime, I'd also like to mention Genevieve will be around for duration of the Expo, and the platform has facility to connect with people. And should you have any questions, please don't hesitate to reach out to Genevieve, and I'm sure Genevieve will be more than happy to answer any questions you may have, or share the experience, which is quite unique actually, what's been happening in Queensland. So thank you again for your presentation, Genevieve. If anyone has additional questions, as I said, do connect via the meeting hub, and thanks for joining us, and enjoy the rest of the Expo. Thank you.
Thank you, Sam.